You are way too vague.
Hi. How are things moving for you?
Oh, dear Lord, I can't see a thing on it.
The March Advisory Board of Health meeting to order. If we can rise for the pledge, please. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. We could have roll call, please.
Klink, here. Hayes,
Here.
Falk, here. Standell,
Here.
Urban,
Here.
Richards, absent, and Smith, absent.
Citizens wishing to address the board. Do we have a sign-in, Tammy?
You have to go get it today.
I can. I don't mind. She's got it. Yeah. Okay. Trey Smith is up.
Good morning.
Good morning.
I am Trey Smith, and if you can look to your left, through the wisdom of our chair, I had a chance to present something that I'm looking at bringing to our county that we put together for Rochester Hills and Oakland County to share and to present. Thank you for that. So right now, I'm talking about a public health crisis that's really meaningful to my heart, and St. Clair County is feeling it. And I want to clearly say this is not an indictment of anything that has or has not been done, but it's just an opportunity, because now there are over $400 million in federal funding that's being repurposed through our faith-based office in Washington that can help address a very tangible issue that we have, which is homelessness, as a way in which we can help prevent suicide or go after what we consider suicide prevention methods through faith-based means. And what we're proposing is potentially making the former health department, Moak Street, a 24-hour, 7-day-a-week stabilizing and command center of not just possibly housing, but also creating a network in which we can find the best ecosystem for people who are struggling with homelessness and these issues. Because the truth is, it's not that we don't have services and resources here. Sometimes we don't have the right ecosystem for somebody to thrive. And maybe if we create something like I would like to call an underground railroad for homeless people, where we can find out where they will thrive best, I believe we can do that through our county, and there are resources privately and also publicly that can help support that. So what I'm asking is for our board to allow me to present a full presentation with data and the different streams to see if this will fit our niche and our approach to doing this. And as you look at this, this is very nice and colorful, well put together, I would say so myself. However, it has to fit our approach, and we got to be more innovative to actually fixing problems, because putting somebody in a hotel or a shelter, it makes us feel better, but the recidivism rate is still high. They're going to go back unless we change their mind. We had to do that ourselves when we had an individual who we took through all the services, even took them to our community mental health, and they just was no change. It's not that they didn't use best practices. The area did not best present the options needed for that individual. And so I'm asking you all to allow me to present, to share it, and then for you all to digest it, see if it fits in our area, in our community, and we can be the first to actually access these pots of money and deal with this population in a unique way. And if you don't like it, the worst thing that happens is you now know that there's money out there for new initiatives if we're willing to be creative and unique in our approach. Thank you so much for your time.
Thank you.
Thank you.
Dave Atkinson.
Good morning. I came to address the Health Advisory Board this morning, and I came here to represent those that don't have a voice. I came to represent, actually, I came here to specifically represent the 100 children that lost their lives yesterday in Michigan. But you didn't read about it in the Portland Times-Herald, and you didn't hear about it on TV channel news. You didn't hear about it. But if you listen real close, Dr. Nevin, I want you to listen real close. You're going to hear the cries. Can you hear the cries? Can you hear the cries? No, we can't. You know why? Because we become deaf to the sound. But the 100 children lost their lives yesterday in Michigan were aborted by their mothers. They woke up yesterday morning in their mother's womb, perfectly healthy. Little did they know what was going to befall them before the end of the day. And there's another 100 women this morning waking up the same way. Perfectly, how do you call it health care, where two perfectly healthy people go in and one always leaves dead? We call that women's health care. And you ask, why do I bring this to you this morning? Nobody wants to hear this. It's a reality. It happens every day. 30,000 abortions took place in Michigan last year. And oh, I know it's been codified into our Constitution that a woman has this right. I don't care how right the state of Michigan says it is. I'm telling you right now, it's wrong. Ms. King, I got to ask you a question. Every day at the school clinics, abortion is presented as a way of birth control. Did you know that God made man in his image, and evil loves death? Loves death. And that's why I'm bringing that to the board's attention this morning, is if we have to have clinics in the schools, and I'm not opposed to health care, basic health care. I don't call abortion basic health care. I don't call sexual promiscuity basic health care. And so I asked as a board, and I know you have a lot on your plate, and I know there's a lot of people pushing back. It didn't, you know, the only thing it takes for evil men to prosper is for good men to do nothing. And we see that there's a gentleman who came here the other day, he was talking about the disparity of because of race, The minorities are the large percentage of people that are aborted every day. So I ask as a board that we would consider the things that we're presenting to our children in the clinics as health care.
Is there anybody else wishing to speak? Okay, moving on. Minutes from February. Take a motion to approve.
Second.
It's been moved and seconded to approve the minutes for February 2026. Is there any further discussion? All those in favor?
Aye.
Opposed? That motion carries. Budget to actual, Greg?
Nothing remarkable.
Okay.
Revenue exceeds expenditures this time, so we're good.
Anybody have any questions for Greg? If not, I would take a motion to approve the budget to actual and recommendation for the transaction registry.
So moved.
Seconded.
It's been moved and seconded. Is there any further discussion? All those in favor?
Aye.
Opposed? That motion carries. Correspondence. Liz?
Thank you. Good morning. In your packet, you see a letter of support to Fort Gratiot Township, additionally, a letter of support to Kimball Township, and then a burst fax from the nursing division and Dr. Nevin clinically that went out to clinicians, just a refresher on measles reporting and testing that was there. Big picture wise, I kind of wanted to discuss correspondence if we could at this point, if that's appropriate.
Thank you.
These requests come in very quickly for a turnaround. So typically in the past, I've had the discretion to support or not, as the health department, sign and return that letter to the township. If we are in support, pretty much 99% of the time, it is a project that's appropriate and public health, would support that. And we've gotten these turned around quite quickly. I just want to verify that that still works for the board. And put it in correspondence, or would you like to know, by email or anything differently? Okay. Then additionally, I think what happened this last time is that they asked for a letter that I would sign or Dr. Nevin would sign, we could co-sign, but they also asked for a letter of support from your advisory board. And I explained that that's going to be difficult in the time frame because we had a couple weeks coming before the meeting. So I'm looking for direction from you on how we want to handle those moving forward. I can just pass them along or whatever the board would like.
Liz and I had conversation regarding this. I think we touched on it even in the steering committee with Dr. Nevin as well. And we just need kind of some direction for where we want to go as far as the advisory board letters of recommendation. So whether that be, being that we only meet once a month, it makes it more difficult because most of these letters are they want it within a week, right? Within 3 days.
Can we do like a DocuSign or something like that and have each of us sign that? Is that a possibility, or is that too much work with what's going on?
Well, it's not so much that part wouldn't be the problem because it usually only is the chair that signs
Oh,
it, I
okay.
think. Or it's even written, Tammy, do you just? Right, right. Right.
Gotcha.
So, the problem is that we don't have time to vote on whether or not that is something that this board wants to support. And I can't just do a straw poll, right? That's not permissible either. So,
continue with the process I just explained. If it falls in line with your meeting,
a
certainly we
timeframe.
can get it on there and move it quickly. Okay, so I'll
I
just
think that's the
respond
only
back
way to do that.
to the townships when they ask for those. Okay.
Thank you.
Yeah, then additionally, this morning, there was a letter put in your packet, I think by Tammy, that was sent into the Board of
Yep.
Health email. And we apologize for not sending that out sooner. Tammy wanted me to mention this. Our email and our whole internet was down yesterday
Yeah.
afternoon, so I apologize for the late notice on that, but we did include that.
So that actually, for reference purposes, will be part of the citizens wishing to address the board. Comment from Jennifer Mahalik.
That's it for me on correspondence.
Thank you. Unfinished business, the solar regulation update. Who's gonna?
I have no new updates.
No, I have no updates either. I
Okay.
believe the final decision on this matter was made at the recent Board of Commissioners meeting, where the decision was made to file the appeal. And I believe we discussed that we would expect this process to play out over the next 6 to 12
Sure.
months.
Okay. Nothing else, okay. Fluoride regulation update. We have the letter to the EPA and to the memorandum from Dr. Nevin to the municipal water systems.
Thank you, Madam Chair. So you'll see this document that I wrote as part of the regulatory process that's currently underway. When regulatory changes are proposed by a federal agency, they typically publish a notice in the Federal Register, and they invite comments as part of the Administrative Procedures Act, soliciting comments from scientists, dentists, toxicologists, and so on. So I submitted this correspondence that you can see essentially endorses the position of the original plaintiffs in the case that was decided a while back in California under the Toxic Substances Control Act. Fluoride Action Network, of course, was the original plaintiff that asked that fluoride in municipal water be regulated under the TSCA as an unreasonable risk to public health. As we recall, the reason we're discussing fluoride is because the district court judge, on extensive review of the science, concluded that the plaintiffs had merit to their complaint, that fluoride did pose an unreasonable risk under existing statutory definitions, directed the EPA to regulate fluoride as a hazard under the TSCA. EPA is appealing, and they recently had their oral arguments in front of the appeal court, at which EPA did not question the science under which this decision was made. They merely have procedural issues with the court's decision. So because EPA does not question the science, meaning EPA is not disputing that fluoride in drinking water is an unreasonable risk to human health. My foot is stomping under the dais here. EPA does not dispute that fluoride in drinking water is an unreasonable risk to health. They are launching this separate regulatory review under a different statutory authority, the Safe Drinking Water Act. And as you can see in the submission by FAN, which is written here by their attorney, Siri Glimstad, they note that even prior scientific reviews under the Safe Drinking Water Act were fundamentally flawed because they did not use an appropriate safety factor, right? So in toxicology, we recognize that existing science is almost always incomplete, and that in order to ensure that a danger identified by current science does not overestimate the safe dose, typically uncertainty factors on the order of 10 are applied to levels which are identified by current science as being harmful. And had EPA been doing that with prior levels of fluoride that were recognized as harmful, for example, causing fluorosis, then FAN and their attorneys argue that EPA would have already acted to reduce maximum concentrations of fluoride in drinking water. Now, this is all preceding the recent recognition that there are other toxic effects of fluoride besides fluorosis, that neurotoxic effects of fluoride are increasingly relevant. And I think there's growing consensus internationally that levels of 1.5 parts per million fluoride in drinking water poses an unacceptable risk, that with at least moderate confidence, this has been associated with adverse neuropsychiatric outcomes. So what my letter points out is that applying the typical safety factor of 10 would result in maximum concentrations of fluoride far below levels that we recommend for prevention of caries. So I think based on what the statute requires, and based on the fact that the EPA is not questioning the science of the TSCA decision, based on the fact that EPA is engaging in this new regulatory process, I think we need to be realistic here in recognizing that changes are coming in these EPA regulations. That at last meeting, I suggested 2 or 3 potential possibilities, but I think based on my review of the regulatory submissions that EPA will be considering in this process, and based on EPA's responses in the appeals hearing, I think it's almost certain that EPA is going to set a maximum contaminant level goal less than 0.7 parts per million, meaning EPA is going to be stating that it is unhealthy to be exposed to fluoride at currently recommended levels. Now, the maximum contaminant level goal is just that, it's a goal. It is not going to be regulatorily binding. It's possible that even though the risk assessment phase of this process may determine fluoride at current levels is unsafe, EPA in its risk management phase may accommodate current practices by setting a maximum contaminant level of 0.7. But any water system that chooses to continue fluoridation at levels of 0.7 is going to be adding fluoride to the water at levels above which I think EPA is almost certainly going to conclude harm is arising. And so for this reason, this is very reasonable speculation on my part, based on my knowledge of the regulatory science, based on my knowledge of the process. And so the memorandum that I sent out to the municipalities is merely informing them of what I think is essentially inevitable, and that within their existing powers, they can choose now or at any point in the future to voluntarily discontinue water fluoridation as being consistent with the best interests of public health and demonstrating a proactive concern for the health of their population. I do want to clarify, given some recent public comments, that none of this should be surprising. I visited virtually every municipality in the county in recent months, informing them essentially of all of the above and recommending that they consider discontinuing water fluoridation because of pending federal action. I spoke specifically to the Port Huron City Council, which would be the decision makers in this particular case. I believe the only municipality I did not address was Marine City, but every other municipality that uses municipal water, I made a point to address in recent months. And because it did come up in a public forum, I did directly speak with Port Huron City Manager Freed about this issue in February, and I did advise him that this memorandum would be coming, so there really should be no surprise there.
And what has the response been?
So we have not heard back from any municipality directly. The memorandum offers municipalities for me to come speak with them should they have any questions. And we remain open to hearing from municipalities should they have questions.
Thank you. You'll see the letter for the non-renewal of the MAP membership. That is in there as well.
Yeah, and Madam Chair, if I could, I think this memorandum speaks for itself, but you see I included this map that shows just how few members of the public are showing their confidence in these recommendations. So the issue was, I was very concerned that MAP continues to recommend that the public be universally vaccinated with the coronavirus vaccine. This is clearly a recommendation that is overwhelmingly rejected by people of all political persuasions. And you can see on that map that there are just a few locations in the state where uptake even approaches 1/4, right? Most parts of the state, you'd barely see 1 in 20 vaccinated with the coronavirus vaccine. So there's overwhelming public rejection of this recommendation for universal coronavirus vaccine. And in good faith and conscience, I simply can't continue to be associated with a professional group that is so blind to public opposition to this measure. And hopefully I've made that point.
Okay, thank you. Teen Health. I think that we're, go ahead.
Oh, did you want to
No,
update?
go ahead.
or-
You can.
I think so, since we met last, we've had 2 additional meetings with the steering committee. Since our last advisory board meeting, also, I think just to reiterate that conversations, that the Board of Education at Port Huron area school districts will be the final decision maker on an entity, moving in and resuming the center. So that has been clear. That's there. We don't own the building, just to reiterate. We all know that. That's not our building. The finances, the grant will return to the state of Michigan there. So the finances are there. What we do have is our staff that we're working through that process, trying to avoid displacement of the staff. I think that's been a focus of the last 2 weeks there. Moving forward, looking for funding sources or gaps that we have and how that will play out. So we are business as usual until September 30th. And our goal, I think, is just, and everyone would agree, is to support the potential providers who may come in there and ease that transition with our knowledge over the last 40 years. We did have the resignation of our mental health provider out of the Port Huron Center. She did resign, and Amy Bishop has been working hard to backfill that. We do obviously have clients on a caseload that need to be seen, so we're prioritizing those cases, and we will be sharing the provider that was in KPAC schools with the Port Huron schools. As we know, we will move forward, I think, this year, unless there's opposition here, but that grant as well will not be, we will not request continuation funding for that. That would have been our last adolescent health center grant. That would be that E3 grant that is solely a mental health provider, full-time out in KPAC. So we're going to work through that process as well.
Then Liz, I have a question. High school physicals for sports are due after April 15th. That's going to continue for at least this school year. You can do that through the teen center, correct?
Through the teen center, yes. What we won't be doing are those extra sports physicals. So a lot of times we were based in the schools to provide those. Schools will reach out to us, and we would send nurse practitioners, staff after hours to do those. We will not be doing that.
Okay.
But the physicals are available at the teen center still, business as usual, till we hear differently. Or that end date
I had
in
a couple
September.
people ask about that, so I just wanted to make sure that I was understanding, that I could get them that information. Thank you.
Okay, Civics Plus.
Update from my end is that county administration is working on developing Civics Plus. That had to be done through, an engineering software company. It is not being done through us directly here, so it's going to take a little longer than anticipated, but they are working on it. So we have talked about the agenda at our last meeting. They need a copy of our agenda, how we want it to flow, and what goes into it, so they can actually build the product that we need. So that's ongoing.
So you may start seeing a little bit differences in the agenda. Same information, but there may be just little nuances that are different as we build this out. All right. Dr. Nevin, Medical Director update.
Yeah, thank you, Madam Chair. If I could, I'll just start by addressing recent development. You all may be familiar with the activist judge in Massachusetts whose many injunctions and stays have been overruled by higher level courts that issued a ruling essentially staying many of the recent changes to the federal vaccine schedule. The expectation is that this ruling will be overturned in due course. I can't imagine an appeal court, and certainly the Supreme Court would agree with the judge's decision-making, which was very arbitrary. It is the Secretary's responsibility to make these decisions. This is a clear example of judicial overreach. So to the extent that this federal court decision affects a recent recommendation by the advisory board, it may be worth briefly discussing whether we reiterate our support as an advisory board for the recent schedule changes. Again, there's no legal concern with our endorsing these changes, despite the federal ruling. As medical director, I will continue to write my standing orders the way I see fit from a medical perspective. The other two aspects of the advisory board recommendation to promote alternatives to MICR tracking and to support our streamlined vaccine exemption process, I think both of those recommendations are all the more relevant in light of these recent developments, because more and more parents are going to question the motivations behind many of these trade groups in questioning these federal recommendations and seek to decide for themselves in consultation with their physician which vaccines are appropriate for them. And so they'll need the very choices that we have offered. But as far as the advisory board having endorsed and supported the recent CDC changes, I will assume that those recommendations still stand, notwithstanding the recent court decision, and I think we can all look forward to that decision being overturned very soon. All right, so now to the important issue at hand here. After many years of faithful service, one of our nurse practitioners has submitted their resignation, and I do want to thank them publicly for their service to the department. In April, we will have a significant underlap in our ability to provide clinical services, because we will not have a full-time nurse practitioner or other clinician at the department. Now, of course, my contract and the position of medical director does call for me to be full-time with my working a minimum of 16 hours. I suspect that as a result of this underlap, the staff are going to have to get used to me sitting in clinic Monday through Friday, 8 to 4:30, because until we replace this nurse practitioner, we will have no full-time clinician able to offer the core statutory clinical services that we are required to provide, namely treatment, diagnosis and treatment of STIs, and then something which is not statutorily required, but which we have offered for many years, namely contraceptive services. So someone is going to have to provide those services. I'm going to have to step in until we can hire a replacement. Now, I think this resignation gives us an opportunity to potentially improve this position to better meet the needs of the department. And what you see before you is a memorandum where I am proposing the development of a deputy physician assistant position to essentially be my deputy in my absence. This, instead of being a nurse practitioner, this would be a physician assistant for several reasons. First is there's been a historic underrepresentation of physician assistants in the department. And because this position would be directly assisting me in my role as medical director, I think the title physician assistant helps to communicate that role. And I would propose the title of deputy physician assistant to further clarify that. I envision this being 32 to 40 hours a week, Again, essentially replacing the existing nurse practitioner position with some additional deputy duties. In my absence, I would be able to direct them telephonically to manage more complex patients in my absence, because I am typically part-time. They would be able to represent me in departmental meetings and so on, and essentially execute my responsibilities in my absence with my direction, or under my direction. So there need to be a few changes made to this job description, and there would need to be a few changes made to my contract and my job description, because I currently do not have direct supervisory authority over any staff member. I would propose that this position report directly and only to me, and that they be my sole report. And so at the bottom of this memorandum, you can see my recommendation. Given the urgent need to fill this position, I would welcome a motion from the Advisory Board of Health to recommend that county administration and department leadership make appropriate adjustments to the medical director's job description and contract to specify direct supervisory responsibilities for the single position, the existing nurse practitioner job description, which you see enclosed, and the department staffing table, and that these revised documents be forwarded to the Board of Commissioners for consideration at the earliest opportunity. It's probably too soon to put this before the board for their meeting tomorrow. It may not be too soon to put all of these materials before the Health Committee meeting at the start of April. And if it may be possible for the board to consider this matter for final action, this would allow the department to post and advertise this position essentially coincident with our loss of this position, because the resignation is effective early April. Realistically speaking, it will take a couple months, maybe 3 months, to find, vet, hire the appropriate candidate. And during this time, realistically speaking, there's going to be an underlap of clinical services at the department. I can fill in for the STI management, diagnosis, and treatment aspects. I'm happy to fill in for some of the contraceptive services that we provide, but I am a preventive medicine and occupational medicine physician, not a obstetrician, not a gynecologist. I last removed an IUD over 20 years ago, and I do not want to do that, nor do my patients, I think. So realistically speaking, we are going to have to put a hold on certain services or refer certain patients out to the community for those services until we can find a clinician who feels comfortable doing those procedures.
Would you like a motion prior to the job description change, or are you thinking that's going to have to be after?
So I would welcome a motion from the Advisory Board of Health to recommend that county administration and department leadership make appropriate adjustments to the medical director's job description and contract to specify direct supervisory responsibilities, make appropriate adjustments to the existing nurse practitioner job description, i.e. at their discretion, and make appropriate adjustments to the department staffing table, and that these revised documents, the Health Advisory Board may recommend, be forwarded to the Board of Commissioners for consideration at the earliest opportunity. And my understanding is that there are plans being developed by the department, subject to the board's concurrence, to make those changes with my input and with appropriate input from council. And I imagine that with the board's concurrence and with the concurrence of administration, we could get a revised job description to the Board of Commissioners Health Committee for the April meeting, potentially for final action.
Liz, or Greg, I don't know which one of you to answer or ask this to, but how, if we're changing the staffing or the manning hours, how does that, is this affected by union contracts at all?
Well, it can go either way, but I'm actually got a meeting with HR director tomorrow to discuss this.
Okay.
And I think this position needs to be a non-union position, so we will go through and see how we make that work.
But is that something that,
This is very realistic. It's
okay,
something we can do.
okay, that was my question, can we do that? I heard your reasoning of underrepresentation of physician assistants, so you're not open to an NP or PA?
So as need be, I would be open to a nurse practitioner, but I believe there's value to this position being a physician assistant. And my preference would be a physician assistant.
And budgetarily, Greg?
Right now, it'd be it'd be a zero, not zero, because we had the resignation of the nurse
Right.
practitioner. The only problem may be in the future with our practitioner at Teen Health. If she were to stay on here after we close Teen Health, that would be a budgetary issue. But if she would move on with another entity, then that would not be. So time will tell on that.
Yeah, and Madam Chair, I suppose this is a good time to discuss the anticipated staff changes with our transitioning to teen clinic. So my understanding is that if we do transition the teen clinic here within the next few months, that it's likely, and please correct me if there's been any commentary to the contrary, but I think it's likely that the key staff at the teen clinic would take employment with whatever organization chooses to run the new facility, whether Port Huron School System takes it over directly, whether it's contracted to a group such as Community First or Great Lakes Bay, as occurred at Algonac, where our part-time nurse practitioner resigned from the county and was hired by Community First. I would think the most likely course of action would be the same, that the key clinical staff would simply be hired. Now, until that happens, we have a full-time nurse practitioner at the teen clinic who may not be as busy over the summer as they would be during the school year. And so it's possible that our full-time nurse practitioner at the teen clinic could work a few days a week here, handling many of those services, and that with our part-time nurse practitioner, we would have potentially 1 or 2 or maybe 3 months of coverage of that underlap. That beginning in April and May, assuming the teen clinic hasn't transitioned, it's possible that I won't have to be here clinically every day. But I think realistically we have to assume the worst, and that there will be an underlap. But best case scenario, we post this position quickly. The underlap is covered by our 2 existing nurse practitioners on a shared part-time basis, and that by the time the teen clinic transitions, which we are hoping will be before the October 1st end date of our grant, and we most likely lose our full-time nurse practitioner to the new organization, that by that time we will have hired a replacement clinician, in my opinion, ideally a physician assistant, to take over those full-time positions here and additionally to serve as my deputy.
Does the nurse practitioner that resigned, is she currently 40 hours?
She is full-time.
37.
37 and a half are her
37.
full-time hours, yeah.
Okay. And then if she would be doing administrative duty, will that take away from clinical time?
So my expectation is that there would be time for all of these matters, right? So our clinical load is rather sparse, you know, compared, this is actually a very desirable job for many physician assistants, because, you know, your typical physician assistant is seeing 10 or 20 patients a day, and I don't anticipate the clinical workload will be anywhere close to that here, right? So there will be time throughout the day for the physician assistant to manage, you know, very, very minor administrative things that may come up. And again, I don't, just to reiterate the fundamental motivation for this, is there's been, several discussions. Well, we want a health department where power is shared between two individuals, and that's all well and good, but I have no power, right? Nobody works for me directly. I have no direct reports. I have no direct supervisory responsibility, and I'm on site, maybe a couple days a week at most, right? So it would be very helpful to me if I had an individual representing me on a full-time basis that could be present in the department when things come up, reports directly to me, is accountable to me, and that can ensure that my medical direction is followed when necessary, when conditions arise in the clinic, right? So, the health officer has an entire staff reporting to her. Head of nursing has a deputy and entire staff reporting to her. I don't have any staff reporting to me. And although my job description and although my contract specifies that I will have responsibility and oversight of clinical staff, traditionally I have not been involved in the hiring of clinical staff. I'm typically not asked to approve the hiring of nurse practitioners and other clinicians that execute my medical direction. This would be an individual that I would have say over hiring and that I would oversee directly. And I would think that this would help to introduce some much-needed balance.
Yes.
If you guys have the motion, I don't know if you have the second yet.
There hasn't been a motion yet.
We've just been discussing.
Normally,
He's-
you have a motion, then you discuss it. but
Well,
you're
this is under
discussing it,
Dr.
just-
This is under Dr. Nevin's update.
I have 5 specific questions so far. Is this going to be budget neutral? Is the pay range equivalent to the person that is resigning or retiring?
That's what the current plan is,
Ideally.
Okay.
ideally.
Well, I do want to add a little caveat there. So the person that's resigning is paid out of a line item, out of our family planning budget. I would guess that the amount of time that this individual is doing administrative type of work, you're not going to be allowed to do that. We'd have to pull that, and I think we can work that out.
Next question. In your letter here, you got supervisor and supervision received. It says, works performed under the direction of the medical director with direct supervision by the public health supervisor. Who is that? The public health supervisor, it's in your letter.
Was that?
So I believe Commissioner Rushing is referring to the job description.
And that's the
That's
nurse
the nurse
practitioner.
practitioner one that
That's
exists
the
right
nurse
now.
practitioner job description that's current.
Okay.
That's not the one for the position being discussed.
Well, I'm concerned because this another one comes up. In case of emergencies, and you're not available for whatever reason, you get in a car accident or something, you're not available, who would that person report to? I think potentially, and I'm just talking from what you've given us, would report to the county administrator in your absence. You know, I think that's a normal structure of things.
So, Madam Chair, this proposal, as you can see in my bolded recommendations, it does require some modest changes to my job description and my contract, because of course, my contract, although I am notionally responsible for providing clinical staff to the department, I don't have any supervisory control over the staff. I don't have any say currently in the hiring or disciplining or firing of clinical staff. So there would need to be some changes to my job description. And one item that has come up recently has been a proposal to have me report directly to county administration rather than to the health officer. And for those who are primarily interested in ensuring the department has a balance of authority, this would clearly make sense for both the health officer and medical director to report to county administration. So my recommendation is that the county administration make appropriate adjustments to my contract and to this job description at a minimum to ensure that this position reports to me and that I have supervisory authority over that individual. If county administration, potentially at the direction of Board of Commissioners, sees fit to change my reporting scheme, that would be fine with me as well, and that would address the concerns that Commissioner Rushing, I believe, addressed. But I would not want our decision on this particular position to be slowed or delayed in any way by that particular issue, because there is some urgency in seeing this position filled at the earliest opportunity. And I would think the ideal timeline to have this job description and all the necessary changes made would be for the April Board of Commissioners Health Committee meeting. So if there are any significant contentious changes that might interfere with that
Two more
schedule.
questions. In the interim, is there anyone qualified in the health department that can fill this until it can get, potentially, if you guys have the motion and forward this, is there anybody qualified to do this in the interim?
Yes.
Because if there is, I'd
Oh,
like
I'm
to get
sorry.
the.
Not as a physician's assistant, but we do have the nurse practitioner roles who will cover, like Dr. Nevin said, with his support. We do have one, my understanding, I'm looking at Amy, our part-time nurse practitioner is trained in IUDs. She is part-time, but she's working the schedule with that. And then Sandy, our nurse practitioner from Teen, has agreed to backfill as well, who is trained in Nexplanons, which the part-time nurse practitioner is not, while we wait for all that training.
And you guys will have your motion potentially and potentially forward to it. I really like the premise of it. I got another question on that. Are you familiar with any other county that has a similar setup as this, where somebody has a underneath medical director? Because I'm not familiar with the other 82 counties that somebody reports to a medical.
Madam Chair, there are some health departments that actually employ two physicians that have a full-time or part-time primary medical director and then employ either a full-time or part-time deputy.
Correct that. Anything that qualified for you, 250,000 and under, it's minimum 16 hours a week. So just those counties, don't include Wayne County or Oakland County, but counties that would be similar to St. Clair.
So, Madam Chair, the question is there a health department that has a intended part-time medical director position that has some full-time deputy reporting to the medical director? I don't know for certain, but I believe that there are counties that have a medical director and a deputy medical director that is a physician.
Just the timeframe, I will not be at the April meeting. I've already sent an email out that I'm not going to be at the committee meeting in April. I'm going on my golf trip. I've done this for 35 years, so I'm going to be gone for 11 days, leaving Monday. So at the committee meeting, I don't think this could potentially make it to our board for action tomorrow night. And I don't believe the consideration in the committee meeting, potentially the fastest track would be to put it on the full board for April. And I believe that would be April 16th, the day after your meeting on the 15th. And if this board supports it, there's going to be somebody that can explain all this to the full board tomorrow night, that this is coming your way, or at least a brief request. You guys do go forward with that. I really like the premise. I think it'd be good, and hopefully you're on board with it and think that it would assist the health department to have somebody there in his absence, because if he's in Ohio or in the Bahamas or wherever he might be, hopefully you go on a vacation sometime. But if there's an emergency, that things can still be taken care of from our medical director's chair just by doing it over the phone. And that would be legal with direct supervision over the medical director.
Why couldn't it go on the April, on the committee?
Well, it could be on the committee, but Carrie Angie sent out an email, and then I saw hers, so I also sent one out that I will not be available for the committee meeting. So now you're going to have 5 commissioners.
Gotcha.
That will
So
be
you're already
there.
down 2, okay.
And, you know, whoever's there at the meeting, they could potentially forward it, or maybe not. You have to take 3 votes to put it on for final action at April. But if you guys are on board on this and you guys move forward with this, if somebody can give this explanation or proposal to the county commissioners tomorrow night or at the April meeting, that the health department is on board with this and think it'd be a,
I think the,
sorry.
I think the April 20th date is more reasonable, because I believe the cutoff for us to put things on the agenda is Friday this week.
Same with
There,
us.
and with Greg's schedule with meeting with HR. I don't know that we'll be fully prepared with a new proposed job description. I'm guessing HR wants to look at wages specifically and some comparisons, but that would be more reasonable for us as well.
And we do it with rare exception, you know, we get a revised agenda. You guys can still do it here. It's still, you have that, it doesn't have to be on your agenda to take action if it's something emergency that you want final action for. So potentially the full board meeting in April, but if you put it on a committee and they can discuss it, at least get some of the question to forward it to the full board. But somebody give a presentation to the commissioners if you go forward with it. I really like the premise, and I think it's a good thing to do.
Would it be appropriate to put it on for the April meeting for a conceptual initiative and then put it on the full board so they get a taste of
Yeah,
it
the
first?
conceptual initiative, of course, would be on the one committee, Human Services.
Right.
And start it there, and,
That would give them a taste for it before it went to the full board.
and if it is needed expedited, that part of the conception, please have a, suggest having a motion that the county commissioners put it on for the full board meeting in April.
Okay.
So, Madam Chair, if I could, if we assume that this position, this revised position is approved by the end of April and is in a position for us to post in early May, which I think based on the discussion is the most likely, most likely possibility, then realistically speaking, it'll take about 3 months. Assuming our position is competitively advertised and we can find a suitable candidate, which I believe we'll be able to. So that we're looking at May, June, July, so into August, before we have a replacement for our full-time clinician at the main clinic here. So given the likelihood, or at least I think what we hope is the likelihood, that the teen clinic will be transitioning during that time, I think it is important to alert the advisory board to the potential for some minor period of underlap where we may need to refer out many of the contraceptive services, which I reiterate are optional, which are not a core function of public health departments, and provided that the board is fine with that period of underlap, I think we can make appropriate arrangements to refer out as necessary during that time.
I think I heard, or at least understood, that we do have some overlap coverage, and so that probably won't have to be, potentially won't have to be. I mean, because in all honesty, we can say that we can refer out, but the reality is there are no GYN providers that people can get into because we're lacking OB and GYN care in this county. So if we don't provide it, and I understand your point that it's not a staple requirement of the health department, but there are a lot of people that depend on it, so.
So I believe, Madam Chair, we could make referrals to clinicians in the Detroit metro area for many of these services. And I will discuss with the nursing staff. We'll have a meeting, and we will plan out potential trajectories here with our staffing and make a determination as to whether letters will need to go out to folks whose long-term contraception is due for removal during the potential period of underlap, informing them in advance of the potential temporary loss of services here, and offering them assistance in referrals to providers in the Detroit metro area.
Thank you.
So if there is interest among the members, I would welcome a motion accordingly.
I do make a motion to recommend the county administration and department leadership make appropriate adjustments to the medical director's job description and contract to specify direct supervisory responsibilities for this position. The existing nurse practitioner job description and the department staffing table, that these revised documents be forwarded to the BOC for consideration.
I'll second that. That was a mouthful.
Yeah, I had a hard time pronouncing all those words. Do you want a roll call vote, Monica?
First, we'll have discussion on it.
Okay.
Is there anybody else that has any discussion on the motion? I think we've heard the explanation. Anybody?
And you had already asked about lapping, right? We have coverage,
Well, there's
potential.
potential for coverage, and they are working on that part of it. But that's going to exist no matter what, whether this position stays an NP position or whether it becomes a,
Well, Madam Chair, I do think we need to acknowledge that the proposal to change this position is introducing about a month's delay into the process. So now, I suppose the question for the Health Advisory Board is if you disapprove of this concept and feel that this 1 month delay is not worth it for the benefits that I believe this deputy physician assistant position will bring, well, then obviously vote against the motion. But if you believe it's important for me as medical director to have a deputy, it's important for me to have some supervisory responsibility and to have someone here full-time representing me and my medical direction, then presumably you would determine that potential delay and that potential underlap is worth it for those benefits that I am requesting.
So Greg, I do have a question. If a nurse practitioner applied, does that mean it would have to be union? Is that what that means?
No, that's not what that means.
Okay,
The job description would decide or would indicate what unit they would be in, and it would be a canoe position, a non-union position. We have non-union nurses on staff right now, so, but, yeah, and I don't know what Dr. Nevin thinks, but I think we should keep this open to NPs and physicians assistants, just to keep the pool large enough for selection. Just listed.
So I believe there's significant merit in making this explicitly a physician assistant position, just as the current nurse practitioner positions are nurse practitioner positions, right? There's been historical underrepresentation of physician assistants, and from my position as medical director looking for a deputy, it would be very helpful for the individual, in my opinion, to be a physician assistant, based on the subtle but real differences in the training and historical roles of the positions. Now, what I might propose is that if we do encounter some difficulty in identifying a suitable physician assistant candidate, which I think is exceedingly unlikely, then in that case, of course, I would be open to expanding the search. But I don't anticipate we will have any trouble finding a suitable physician assistant candidate. So my recommendation, subject to the board's concurrence, would be to define it as a PA position, at least initially.
are you considering, like, if after 1 month we don't get a suitable candidate, then we would open that up? Is that what you're thinking, Dr. Nevin?
Yeah, I think that's reasonable. After about a month or so of having this position posted, if it appears that for whatever reason this position is not competitive in the job market, then we adjust accordingly. Now, it may very well be that the wages that we have proposed may not be high enough for the market. We'll have to do a study as part of the HR process of modifying this. As we know, wages in the healthcare sector, they're not increasing as much as we would like, but they do increase over time. If the position is not attracting qualified candidates, then I would propose we consider either a change in the wage, or we change we expand the qualifications to include NPs.
So that would be something we would have to reconsider in May, maybe, or June, is what you're thinking?
Well, it may indeed be something that we could discuss at the May Health Advisory Board meeting, because if this position is posted expeditiously, assuming, and I don't want to presuppose, but assuming that this meets with Health Advisory Board concurrence today and Board of Commissioner concurrence at its April meeting, then presumably we would be in a position to post this in late April, and we would have 2 or 3 weeks of experience with the posting by the time of our May meeting. So I would be happy revisiting this and providing an update at the May Health Advisory Board meeting.
Thank you.
Yeah, I think it's not a concern at all. And I found with our assistant district attorneys and other people that work for the government, to have a solid 40-hour week, and you're working for the government rather than a private sector, you're going to get paid less, but people want that because it's very solid. So I don't think that's a concern that's going to happen. So if it is, address it when it comes up, but I don't think you're going to have concerns over it.
Part of me feels like we might be I feel like we're putting the cart before the horse a little bit for the fact that there hasn't been a decision regarding the combination of the health officer and the medical director position. That would change this, in my opinion. And you haven't had the conversation with HR yet. So it feels like, I understand the time necessity of this, right, because of the resignation. I get that. And if it were to be happening, now would be the time for it to happen because of this resignation.
Madam Chair, I can address one of those points. So I anticipate it's reasonable for us to have all job descriptions and contracts reflect the will of the board to potentially change leadership of the department at will, right? So reporting to the health officer / medical health officer is a reasonable phrase to use in all job descriptions. Now, in the event that the board were to decide to consolidate leadership of the department and medical health officer position, there would be arguably even more need for there to be a deputy medical director because of the important role of having the medical health officer or medical director's direction be implemented potentially clinically and to have representation at meetings. So the need for a deputy would, I think, be even more clear in the event that the chair is describing. From a practical perspective, I am tied to St. Clair County, right? The department has expressed extreme discomfort with my being more than, a short drive away from St. Clair County in the event that I am needed here. It's very difficult for a medical director to be subject to those conditions. I don't take many vacations, but it would be nice if I could take a vacation every now and then, right? And know that there is someone that can represent me in my absence. And having someone that reports directly to me and that I directly supervise, given the nature of medical direction, given the nature of the authority that a physician assistant holds, that would provide for the equivalent of on-site medical direction through my telephonic or virtual direction. That individual would essentially be serving in the capacity of medical director in my physical absence. And that same reasoning would apply regardless of whether I have departmental administrative authority or not, right? So this change would permit me to, cross the border and, see my family in Canada and not, have to worry about rushing home at a moment's notice because I would have a trusted deputy here representing me as needed. And I think that it would, the rationale for this position would apply equally regardless of what the board decides to do in that regard, right? Head of nursing has a deputy, right? Health officer has many deputies, right? So it stands to reason that the medical director or medical health officer would also have some form of deputy.
So if the
I just
person,
add a clarity on that. So for me, so everyone knows, as we have many new members on the board, as a health officer, my deputy is Greg. So Greg is recognized at the state level to sign for things, or in my absence, if I was, something happened to me tomorrow, he could step into that role. So I know Dr. Nevin isn't suggesting that this role replace that, but I wanted to clarify that. So as far as the health officer and administrative, Greg has that ability to do that. That's not what this role is for. This is to support him in his medical direction. Previous to Dr. Nevin, we have always had contracts with other medical directors to provide coverage. And I don't see this as unreasonable. I support this mid-level provider and change and support for Dr. Nevin, but I just want you aware that there is a process, and Dr. Nevin can seek support from other medical directors from Macomb, Sanilac to cover, and that's how it's worked, so. And I'm
Well-
sure they ask him for coverage too.
Madam Chair, I think we should discuss this, because my contract and the expectations of the department in this regard, I think are wholly unreasonable. So the expectation is that when a medical director is absent for whatever reason, they decide to go to, Illinois for a week. The expectation has been, very unrealistically, I think, that they find another medical director to take their place. And what does this actually involve? This involves days of paperwork, right? So for another medical director to actually take over medical authority for the operation of a health department requires this substitute medical director to sign each and every standing order that's present, right? To register as the payee in all of our insurance registrations. It requires that individual take over responsibility for supervising various clinical staff. This is not a smooth or simple transition. Now, when I was hired back in July of 2023, and this is a matter of public knowledge, I took issue with the fact that it was the department's expectation that I blindly sign hundreds of pages of medical orders that had been written by someone else without having time to read them. And I said no, because as medical director, I'm responsible for everything that's in these orders. It's going to take me time. And realistically, it took about 2 or 3 days for me to review everything and sign. And during that time, the department was unable to utilize those standing orders. So it's unrealistic for health departments to expect that medical directors will find another medical director to substitute for them for routine vacations or brief illnesses. The deputy medical director position is in part designed to address this concern, that as medical director, I can issue medical direction from my family's home in Illinois. I have a medical license in Illinois. I can practice medicine in Illinois. I can call up my deputy and issue direction to them, and they can implement it here. We don't need to eliminate the medical director and replace them with someone else simply because I'm out of the state, right? If I happen to be in the hospital under anesthesia, right, just as the president sometimes has to hand over authority to the vice president, the physician assistant can operate in my absence for brief periods, and they can be deputized to make decisions on my behalf. I'm comfortable with that. This is far preferable to the very unrealistic situation where we expect some medical director to just have perfunctory rubber stamp authority over things without any true understanding and any true oversight of what's happening in other departments. You know, I think we need to take this up for a while. After the loss of our initial part-time medical director, we still don't understand exactly what happened there, but our first part-time medical director, who left very quickly after the separation of the two positions, after their departure, it was assumed that we had competent, qualified medical direction because there was someone down in Macomb that was titularly filling that position, right? But did that individual actually ever come up here? Did the individual actually read and sign all of the orders? Did they actually ever speak with the staff? I don't know, but it's reasonable to ask if we were having truly effective medical direction under that model. We were having medical direction in name, but were we having truly effective medical direction? This proposal is designed to address these concerns. It will ensure that there is a deputy that is reportable to me, that is on site regularly and consistently, and that can serve effectively in my physical absence for brief or even prolonged periods as necessary. I think this is far preferable to the model that we had, which in my opinion was probably not providing the type of effective balance which the Board of Commissioners wanted. If the medical director that we name is never here, doesn't really know what's going on, maybe hasn't carefully reviewed all of the medical standing orders and policies, are they truly serving as an effective check against the concentration of authority in the health officer position? I would say no. Now, my proposed solution addresses this.
Thank you. Any further questions from the board? Do you have any input, Alice?
No, I just want to reiterate that I agree with Dr. Nevin and the need for this.
Yeah.
I was just trying to explain how it has worked and how it works in other counties. And I think we're talking about chronic gaps versus a short-term need there. And there's two different situations. This is a long-term a solution that's there. But there are those short-term coverage things. And if Dr. Nevin doesn't feel comfortable with that,
Right.
that's okay.
Thank you. Go ahead. Leanne. No. I
Okay.
meant Leanne, sorry.
I thought you were looking at David. Klink, yes. Hayes,
Yes.
Falk,
Yes.
Standell,
Yes.
Urban.
Yes.
Okay, that motion passes 5-0. Okay. Liz?
For my report, I know I emailed all of you
Yeah.
our 2025 annual report, but I did include a hard copy in there as well. I want to give shout out and compliments to our PPEV team. This is done in-house, the design. They gather all the information, lay it out every year for us, and they do a great job. It's outstanding. So I guess if you have any questions about that, I'm happy to answer, or at a later date, if you want to email me any questions. But we want to make sure the board has that and sees the great work that's being done.
Thought it was very well done.
Yeah. Good job. Well done.
Also, the strategic action plan, we've been talking about that a little bit at each meeting. So we do have a framework to do that this year. We will be doing that also pretty much in-house at this point. Previously, we have hired a consultant, but again, I believe our PPEV team, as we have it newly structured in the last 3 years, has the capacity to do that. The goal to start is in April, so you'll be hearing more about that. We are looking for more input from this advisory board. With that. As we move into the divisional summary report, quick update on the sanitary code that Steve provided. We always have questions at every meeting, and we're watching that closely, so I wanted to get ahead of that for you. So that Senate Bill 771 was discussed on March 10th. It was not voted on, it was not moved out of committee, and it remains at that level. So Steve indicated that there was a lot of opposition, more opposition this time than had been in the past. So we'll just keep watching that closely. On the environmental health side as well, the work plans are complete for the Eagle renewal funding for the beach testing and that source tracking that we do every year at the beaches. Steve indicated that this week, I think Dr. Nevin also has been looped in on that the source testing from last year's samples will come back. So the actual source of those shutdowns of the E. coli, they're source tracking back so we can see if it was, dogs, waterfowl, those things.
And what did we find from last year's?
Geese, thank you. There's a number of human. We
Yeah.
don't think it's human, but,
Right.
we have guesses, yeah.
Did we find last year what they were? We actually did source track last year. Okay,
So that'll be new and
Yeah.
help us, I guess, make some decisions, or at least give that information over to the cities, the townships, the parks, if they want to implement any changes that would,
I don't don't know how you
eliminate.
stop geese.
Yeah, I don't know. Well,
Well, I do know, right, but, anyway.
right.
No messing with the Canada geese.
That would be more of a lead problem than Monica?
Also to note, WIC in the Title X financial audit was complete. We do
Yeah,
not
very nice.
anticipate any issues with that. I wanted to point that out because we get a lot of questions. I just sat down, Greg, Jeff, with Commissioner Samasco. We get a lot of questions on our finances. They are complex. I know you can see that when we give those, that information over monthly. But we are audited quite often in a very detailed manner. So we don't anticipate any issues, but I'll report back once we receive that final report. Touching on maternal infant health, I did want to mention, their January caseload was 253. They have seen, I wouldn't say significant, but they are seeing an increase in enrollments and visits that are there. So that is our high-risk program, home visiting program for moms and infants. Also, we are having a really nice response from it's called the Academic Center for Family Medicine, which is our resident program at McLaren. And I believe we talked about that being a little bit of a gap fill for our OB patients. Women in this community can be seen by a family practice resident, and they do have an obligation to do so many deliveries, right? So that was kind of a gap fill that we're seeing, and it's working. It's worked out really well. And there still is room for more referrals. So, I wanted to
Dr.
update.
Taster is overseeing that, isn't he? Yeah.
Yeah, so,
And Dr. Fabian is back. I heard that. I'm sorry, Dr. Nevin.
well, I was going to say, Madam Chair, so I was a family practice intern many years ago at Fort Bragg, North Carolina, and we essentially had three chief complaints there. We had broken bones, twisted ankles, and childbirth. So what OB-GYN experience I have, I had at Fort Bragg many years ago. I believe we were talking about this. I must have delivered 20, 30, 40 babies in my year there and did many of the procedures, which I don't think I should be doing 20 years later. A family practice training requires that you develop experience with obstetrics because family practice, the expectation is that you will manage some uncomplicated pregnancies and potentially deliver your family practice panel patients as necessary. So it is a great boon to the community to have those additional residents able to assist in some aspects of OB-GYN care in the community. But it's not a full replacement, right? It's not a full replacement for having multiple independent clinics. And I'll just reiterate, given our birth rate here in the county, given the success of our family planning contraceptive program that we offer here, given the success of that, our birth rate in the county is such that we simply can't support a large OB-GYN population of service providers here. When you have 4 to 5 deaths a day and only 3 to 4 births a day, that means whatever OB-GYN labor and delivery ward you have is fully staffed with staff standing idle for many hours of the day, and it just doesn't make economic sense for healthcare facilities to provide that. So unfortunately, this is helpful. I'm glad to hear it, but I think we need to be realistic that the trend is going to, unless we change fertility patterns in the county, unless those change over time, I think we need to accept the fact that more and more babies in the county are going to be born in the Detroit metro area for simple economic reasons.
Liz, I do have a question. Is the Help Me Grow referral pattern helping to increase that? Because that was just started in January for the MIHP, or is that just something that we just happen to notice?
Essentially, I don't have information on that. I'm going to look to Amy on that.
So that's the hub transition to the Help Me Grow. So I think that it's easier to use and facilitate referrals through than the old hub was, so that very likely does
Because I know that just started in January. That's why I was asking. Okay.
I hope so. Right?
Remains
I
to
hope
be
that's
seen.
successful, as well as we move forward there. Immunizations are conducting their VFC, so that's your vaccine for children, immunization compliancy site visits to county VFC providers. And there are 14 providers in our county. We are included in that. So Barb Tadero, our immunization coordinator, goes out and does those compliancy visits in our 12 offices around the county who do offer VFC vaccine there. So she's in the midst of that. Under the data group in your PPEV section, I want to update on DocuSign, and Dr. Nevin also has information on that, so we are working hard with DocuSign. And Leanne brought this up probably a year ago when you said, how do we sign a mortgage and not sign waivers this way? So we are working, we are close, I think.
This close,
It's-
this close.
It's happening.
All the technical parts are done.
Yeah.
It's ready to go. It's just getting the language plugged in with legal's approval, I believe.
We want to make sure the language that's put in there is appropriate.
Once the language finalizes, we can hit go on it like in a day.
So staying on top of that. Then there was another community health improvement plan meeting that happened last month with some good participation. So that's continuing on as well. And that was it for my report, besides what's in your written report. Those were just some quick highlights.
Thank you. Okay, items from members. Does anybody have anything?
Not for me today.
Yeah, I did have something, Liz, and I just wanted to get more knowledge on this. Someone had, received a text about this one group, and if you could fill us in on this. It is
I will try.
CSCB, the St. Clair County Community Service Coordinating Body. And I didn't know about this, and it's quite, as far as the full body members, it's quite extensive with all the different groups here in St. Clair County. And some of the questions that I had, first one was, how did this group come to be? But then I found it as I was going through their website. So this has been around for a number of years then?
Yeah, so that was initially my understanding, started way before me, by previous health officer was part of it, John Parsons, Mike McCartan, Juanita Giddings, leaders in the community came together and formulated this group. They exist in other regions throughout Michigan as well. We're not the only CSCB in Michigan. They're throughout the state.
Okay. And as far as, well, as I was going through it, go to a lot of meetings, and I'm always looking for the agendas and the minutes. And I didn't see anything to that on the website at all. And also, as a public, are they allowed to attend these meetings?
Don't believe so. I'm not in on the details of the bylaws. I don't believe so.
Okay.
That
They're
are
a
there.
private organization.
I'm looking towards Leanne because she's on the full group
I'm
as
actually
well.
not on the full, I'm on
Oh, are
a
you?
partial,
Oh,
but
partial.
Jen is the full.
Okay,
I only
I
get
don't
to
believe
go-
so.
I only get to go when invited or when I'm representing Jen.
Right.
But
I think it's an agency meeting. It
is mostly
I
agency
have not seen
meeting.
public there. I don't believe it's public. I'm not aware of the rationale as to why the minutes or agendas are not posted.
So there's
But
no
I do
funding.
attend. There is, so you pay dues based on the size of your organization.
That is correct.
Right, so anywhere, I'm guessing, at the dues amount.
I don't know
I
the
think the
dues amount,
county,
but it is a dues.
the county pays as a whole. It's not just the health department that's a member of the CSCB. It's veterans, the sheriff's office, oh, I'm looking out there, maybe the library. We have Lisa Beeden as a Board of Commissioner member, that's there as well. So there's
Wings, Safe Horizons.
Sheriff's Department,
Sparrow, library, other.
legal aid,
Yep, Lakeshore Legal Aid is there.
Oh, for the full body members? Oh, yeah, it's
Yeah.
huge.
Very,
yeah.
very
Yeah.
extensive. Pretty much any organization, mid-city, like, so any organization that provides services in the county is typically a member. And I can't honestly answer that either, Liz. I think maybe public has attended some, but not all of them.
I don't think
so.
they do. It's just so large, you think there's public there as well, but it's all
And
these
that could be-
entities.
that could be.
I did answer, Commissioner Samasco sent me similar questions, Dawn, and I can forward those answers onto this group, if that'd be
Okay.
helpful.
Yeah, that would, I just found it very interesting. I'd never, had never heard about this group before. And like I said, I was just, so many people.
And the goals
so many
are
groups on here.
referrals, right? Understanding what other organizations are operating within St. Clair County, so you can appropriately refer people. It's about almost staying in your own lane, so if someone is already providing that service, you don't want to duplicate service. There are subcommittees,
Yeah.
there are goals, there are strategic plans. It's very, very well organized. It's, what I've heard in my meetings is that receive a lot of accolades for the way it is organized there, and it is very well, I think it's very well organized. It helps us disseminate information through the subgroups. So subgroups, again, now I'm going to look over at Elise, because she's on many of the subgroups too, through health education. So there is a substance use prevention treatment subgroup. I have sat in on those meetings, and there are now additional staff members in my place that sit on that. There's an adolescent subgroup, housing. Yep, childcare. Right, it does change depending on what's going on in the community, what the needs are, and what the focus is. So there was a focus on early childhood. Early childhood is there, right, when we needed more daycare providers. And we report out what's, what's going on.
With,
Well, 16 years that I've been a county commissioner, I was not made aware that St. Clair County has been paying for this and that we're part of this group. You said Lisa Beaton, she has never given us one word on it at the committee meeting, and anybody of her predecessors that's ever reported here. So I don't know if you have any attendance by the Board of Commissioners at this thing. Do you have anybody dedicated to go to this meeting? Do you go?
Yeah,
or-
I do. I go to what's called the steering committee meeting. That's much smaller. And then, like I said, Elise is on subcommittees
Well, it meets bi-monthly, correct? The actual.
every other. So your steering committee meets 1 month, and then the full committee meets the other, and then moves on from there.
Do we have any employees? Because
Yes.
I'm
Yeah.
looking at it. We got employees dedicated to this that are getting paid to go to this? I wasn't aware of it at all until just recently.
Well, I'm sure the chairs would be happy to present, give information over if
We
you
got a
want
lot
more
on our
information
plate.
on it.
I'm
Yeah.
just starting to get into it, and I'm gonna, because our community mental health is in there too,
Mm-hmm.
and Deb Johnson sits on the board. So I'm gonna be doing my own research on it.
Sure. I'm happy to, if you want to email me specific questions, and like I said, I'll forward on the questions I provided to Commissioner Samasco as well for everyone. But I know from my perspective, I just want to say, I feel it's very valuable for us to be there. It helps people refer into our services and what we're offering here.
do you think they would be available to do a presentation at one of our
Absolutely.
meetings? Okay.
Yeah, I bet you they would love it.
And also, I'd like to put in a word for Trey, and if we could get him I'd love to see him on the agenda, so he can do presentation.
So, Madam Chair, when we refer to this body, it's not entirely clear who "they" is. Presumably, there's some authority. There's some individual or some position that does the work of organizing this, that accepts whatever funds the county gives to this organization. Presumably, there is a person or persons in charge. Now, we mentioned the steering committee. What is this steering committee steering? Presumably, they're steering the allocation and use of, to the extent that county agencies participate, they are steering the allocation and expenditure of county funds, right? So to the extent that county agencies contribute their time and contribute their consent to the operations of this department, this organization is essentially conducting pseudo-governmental operations. Now, we have taken great steps here in the Health Advisory Board, which is to advise the Health Department on its policy. We've taken great steps, including televising these meetings, ensuring ample opportunity for public comment, ensuring ample opportunity for the public to review proposals and memoranda. We emphasize transparency and accountability in the Health Advisory Board. And presumably, the advice and recommendations we give to the Health Department will reflect that accountability to the public. I see this Community Services Coordinating Body as essentially usurping both my responsibilities as medical director to advise the health officer on medical matters and usurping the responsibility of the Health Advisory Board to advise the health officer and health department on similar matters of policy, without the necessary transparency and accountability which defines the public's expectations of public service. This organization's meetings are closed, decisions are made in the dark, there is no compliance with the Freedom of Information Act or Open Meetings Act requirements. This is essentially a shadow county government that is directing the allocation of taxpayer resources. And of particular concern in this regard is that the steering committee, which presumably steers the allocation of county resources, is represented by the city of Port Huron and no other municipality in the county. So what I'm proposing is that the health department engage in an investigation into our activities with this board, first to ensure compliance with all necessary laws and regulations. Even if this organization is technically complying with all the laws and regulations, it is an important question to ask, should it be exempt from the Open Meetings Act, and should it be exempt from the Freedom of Information Act? I would think not. I can find no statutory or regulatory basis for this organization existing. There once was one, but it was repealed by the legislature. If the legislature found it fit to repeal statutory authorization for this board, then why is it continuing in the absence of this statutory authorization? If you look through the annual reports, you'll see that this body takes credit for many things which are the sole responsibility of the health department. I thought it was the Health Advisory Board that was supposed to advise the health department. I thought it was the medical director that was supposed to advise the health officer on medical matters, not a shadowy, unaccountable body. So what I would propose is that we do an investigation, potentially consult with counsel, with the aim of determining if this body should exist, whether there is even a need for this, given that we already have a health advisory board, given that the Board of Commissioners already has a health committee, and given that we already have an emergency management agency within the county. If there is an actual need for county agencies to be additionally represented in a forum beyond these accountable bodies, who should run this organization? Should it be, as I believe, community mental health? Or should it be the health department, accountable to the Health Advisory Board and accountable to the Board of Commissioners? This is what I would propose our investigation focus on, and that we make recommendations to the Board of Commissioners, potentially for policy governing agency interactions with this body absent some sort of regulatory framework. And if a regulatory framework is considered appropriate, if it's appropriate for this body to continue, and if it's appropriate for this body's work to continue in a publicly funded manner, is this worth developing some sort of health regulatory framework to ensure the accountability that's currently apparently absent? So we have the power in the health department to issue regulations that could, in theory, provide a necessary regulatory and statutory foundation for this body's operations. If the body is important enough to exist with county agency involvement, then I think it's important enough to have these proper safeguards in place.
Okay. Did you have anything else on that, Dawn?
No, I did not. Are we gonna?
I once again feel like this is another freight train coming through, right? You knew about it, you knew about it, you knew about it, Commissioner Samasco knew about
I
it.
had no idea.
You didn't, I didn't, you didn't, well, you did, you sit on it, you probably didn't. And it's meal pieced together instead of an actual, if there's a problem, putting an actual item on the agenda that information can be gotten ahead of time and a real discussion can happen on.
Madam Chair, if I could, I think that's
No.
what's being proposed.
Yeah, I understand. Do you know?
I
who-
wasn't prepared for the question.
Exactly.
I will go back to Commissioner, what I did email Commissioner
Okay.
Samasco, like I said, and send that out.
is
I'm
the
not sure
chair?
if Commissioner Rushing, have you seen that? Did he share that with
I've
you?
had it for about 2 weeks,
Okay,
and I didn't think it was gonna be discussed
There we go, 2
today. We
weeks.
got so much on the plate anyways,
yeah.
I didn't
not
know
only
about
with
it.
the health department, but other things that the county's looking at. So, if
That's
there's some good to this, let everybody do some research. I don't think it needs to be an action item at this point. I wouldn't want to take any action item until I do my research.
Exactly.
And I'll be talking to you about specific questions if I have them. But what you brought up, really all the county commissioners can do is give direction to the county, the health department, or whoever is on that. They want to have this board, they can have it with or without us.
Right,
We can't eliminate the board anyways. All we can do is stop the funding.
the funding,
And
correct.
giving whatever the health department, okay, you're not going to sit on the board, potentially. But I'm not ready to make those decisions until I do a lot more research.
And I want to simply say that I had gotten a text from a friend about this week. I had no idea. I had no idea about the commissioners in this at all. So
Do you, I'm sorry,
I
who is
just had a
the,
question.
who is the director, or who is the chairperson of that?
Of CSCB, you mean?
Yeah.
Yeah, Scott Crawford and Deb Johnson, I believe, are co-chairs, or one's a chair and one's a vice chair. And then there is a very part-time staff member that is paid out of those dues. I did give over what I had for the budget, I believe to Commissioner Samasco as well. Primarily, those dues pay for that very part-time staff member to do the agenda, to do the minutes, to coordinate the meetings, maintain the website.
And then Greg, do you know what we pay in dues for that?
We don't pay them, the county pays them. as
Okay.
For all the members.
So they pay for everybody?
Yeah, it doesn't come out of our budget.
Okay. Thank you. Did you have something, Paul?
No, I just wanted to know where we got to go to get more information. Or can I get more information about this?
Well, Madam Chair, that's the problem. This organization operates in the shadows. There is no publicly available documentation. To my knowledge, there isn't even a publicly registered 501c3 or other nonprofit that receives these funds. It is entirely unclear who is getting this money and what accountability exists within this organization to ensure that these funds are not being misspent.
Well, it sounds like there's at least 2 commissioners that are on it, so we'll move
Can you
forward.
share what you,
It's a work in progress.
Yeah, exactly.
Right. And I think it was mentioned to have them present. I
Yeah.
think that would be a good idea.
Yeah.
And I'm happy, like I said, to share the email. That might be a start for you. There is a website where anybody can go and see what's there. It's just what Dawn was mentioning, they don't get into their minutes or agendas.
got it, okay, thank you.
Do you have anything for board member input?
I don't.
Okay. I just have
have
2
to
things.
answer this.
Oh, go ahead. I just have 2 things. Thank you, Trey, for that, just blip it on what you're working on. I would like to see a further presentation.
I agree.
And I think if everybody is amenable to that, then next month, or, is that good? So we will put you on the agenda for next month for a full presentation on that. And then just, we don't comment on public comment, but I just want to clarify, the teen health centers do not provide abortion counseling for any student or any teen or any person that comes into the teen health center. Abortion is not birth control option. So that is not, I just want to make that clear, that that is not happening at the teen health center. It's not happening.
Well, Madam
So-
Chair, we should clarify. So in the course of my quality assurance review and investigation of activities at the clinic, I concluded with high confidence that the staff were not directly providing counseling of that nature. That would be against the law.
Correct.
The staff were not doing that. That being said, if an individual visits the teen clinic and is presented with material, educational material, pamphlet, or so on, and that pamphlet directs the individual to a website, and that website then prominently advertises the availability of abortion services, that may not be a violation of the letter of the law, but it's very clearly a violation of the spirit of the law. And I could not confirm that individuals who visited the clinic were not exposed indirectly in this roundabout manner to websites that might have provided them counseling of this nature. It's a very slippery slope. It's a somewhat fuzzy line, right? And I think the concerns of the public were that while we were not in violation of the letter of the law, we were at least in violation of the spirit of the law, not just about potentially promoting websites that indirectly promoted abortion, but also that the presence of significant amounts of educational material about sex in a clinic on school property, potentially with children exposed to this without the parents' permission, while not technically a violation of the law that requires parental consent for sex education. It was certainly not within the spirit of the law, and certainly not what some parents might have expected from a clinic on school property. So I do think that the public concerns in this regard do have merit through this indirect path of exposure, which was the focus of so much justifiable recent concern.
However, that is no longer the case.
That is definitely no longer the case.
And
That's correct.
our staff never counseled anybody on abortion as birth control. I just wanted to make that
To my
clear.
knowledge, that is correct.
Thank you. All right, take a motion for adjournment.
I'll make the motion to adjourn.
I second that.
Been moved and seconded to adjourn the meeting at 10:45. All those in favor?
Aye.
Aye.
Opposed? We are adjourned. Thank you, everyone, for coming.